Hey everyone, welcome to week 2 of healthcare reimbursement. Let's go ahead and get started. Chapter 2 is going to introduce us to health insurance and managed care. Some of you probably have an idea of what insurance is, but it is a contract that you go into with an insurance company. And the contract is saying that you will pay a certain amount each month called a premium, and in return, the insurance company will pay a portion of your medical bills, for example, if you have an injury or get sick. But insurance is not just for medical bills. You have automobile insurance, disability if you get injured and can't work, liability insurance, we talked about that last week, property insurance for your home, life insurance for when you die, and then your family or your beneficiary would receive money. Okay, managed care is basically a type of health insurance. The managed care companies have contracts with providers and facilities to give their patients basically discounts on their health care. Okay, and again, we're not going to be going over these knowledge check questions together because it would just be me asking and answering the questions myself. But I think these are good questions to think over. So pause the video and then when we get to these, just maybe think them over. Some of these questions might help you look at things in a different way, maybe. You never know. Okay, I'm going to touch on these things very quickly, but there are a lot of them. But like I said last week, this is a lot of really good information that I wish I would have known before, picking out insurance for the first time. Okay, I think to understand the meaning of health insurance, you have to first know the difference between medical care and health care. When someone comes in that is sick or injured, managed care is the process of identifying, or medical care, is the process of identifying their disease or injury and figuring out, what treatment that person will get. Healthcare is all of that, but it also includes the preventative services. So ways to help people to avoid getting sick or injured in the first place. So preventative services could, catch a health problem before it becomes too bad. And that means the treatment's going to be a lot less intense and also a lot less expensive. Okay. Express versus implied contract. So when you go into a hospital or a doctor's office, you have an implied contract with the provider, which is them agreeing to treat you. And you also have an express contract. These are things that are expressly stated or actually stated in the health insurance contract, like doing an annual physical exam on the patient. Stop loss or excess insurance is a plan that helps you out when something extreme or significant happens that requires a lot of treatments. There are two types. So aggregate stop loss plans are for, like a specific time period. So say July 2023 to July 2024 or something like that. And then specific stop loss plans could be like a cancer policy, because your regular health insurance will not pay for all of the extensive treatment involved with cancer. So you could get a cancer policy to help cover all of those expenses. Okay, we already talked about health insurance and premiums, right? That monthly payment that you make to the health insurance company. A schedule of benefits is also called covered services, and that's exactly what it is. It's a list of services that your health insurance plan will cover and pay for. For example, annual exams are covered, whereas plastic surgery, something that is not medically necessary, right, would be a non-covered service. A carve-out plan is when the insurance company offers a specific health benefit that is kept separately from the health insurance plan. So, of course, you would have to pay more for this. But examples of that would be like dental insurance or vision, prescription insurance, mental health, or even like a burn or trauma plan. So these things aren't typically included in your basic health insurance plans. Most health insurance plans are fee for service, meaning the provider receives payment after the service is provided to the patient. Health plans will have a fee schedule, which is just basically like a list saying what they will pay for each specific service. An indemnity plan lets you go to any provider for healthcare. And this is specified because most health insurance plans will have a list of in-network doctors that you can choose from. And the plan will pay for that. Meaning if you go to someone that's out of network, they will not pay what they say in the fee schedule. So you have to be careful when choosing doctors to make sure that they are in network on your plan. Okay, managed care, like I mentioned before, is the patient getting a discount for going to a doctor that is a member of that managed care organization. Like they have a deal with that MCO. A prepaid health plan is very similar to that. There's a contract between a managed healthcare plan and network providers. So doctors and facilities that are within a community, right? They're in a network. And they agree on a set amount of pay on either a monthly or a yearly basis. So the doctor or the facility will take care of each of their patients' needs for just that set amount each month or each year. And so what this means is that a patient that does not have a lot of health issues and that requires less care would be a bigger profit for the doctor, right? Because they're not having to do as much. So they're not having to spend as much money on this person. Whereas a patient that requires a lot of care could be financially a loss for the doctor. Okay, the policyholder is the one who signs the contract with a health insurance company. So they own the policy. An enrollee or subscriber is almost the same thing, just with a managed care plan. Okay, a third-party payer is an insurance company like Blue Cross Blue Shield. I think we touched on that last week. A payer mix refers to all of the different health insurance companies that a doctor gets paid by. And the reason doctors keep track of all this information is because typically they will get more money from a commercial health insurance plan like Blue Cross or Aetna than a government plan like Medicare and Medicaid. So they will sometimes limit the number of Medicare or Medicaid patients that they'll see just because they don't get as much money for them. If a health insurance contract has a guaranteed renewal provision in it, the health insurance has to offer to renew the policy as long as the person is paying their premium. So if you have this provision, they can't drop you unless you're not paying. Okay, so remember I said the premium is how much you pay every month. If you go to the hospital, say you broke your arm, you will have to pay the deductible before your insurance plan will pay the rest. So typically the higher your premium is, the more you pay each month, then the amount you have to pay for your deductible is typically a little lower. But the lower your premium is, the less money you pay each month, the higher your deductible is. So just for example, say, I'm just making up numbers. Say your premium is $300 a month and your deductible is $5,000. If you break your arm, your insurance company will not pay for anything until after you pay that $5,000, that deductible. But say your premium each month is $500. Okay, then your deductible may be lower, like $3,000. So you only pay that much when you break that arm. So it really just depends on your situation. If you or your kids are sick or get hurt a lot, it might be better to have a lower deductible. But don't take my advice. Okay, a lifetime maximum amount is the max amount of money in benefits that the health plan will pay for a person. So when someone is very sick, say with cancer, like I said, the medical bills can get very high. So health insurance plans weren't able to just continuously pay for all the treatment. And so that's why they started creating these carve-out plans that I had mentioned. And so they do set a lifetime maximum amount on people. Riders can increase, limit, delete, or clarify what the insurance covers. So it's almost like adding this little extra thing. Like for example, there's a rider that you can add that covers 100% of non-surgical care within like a certain time frame after, say, a car accident. Okay, so there's a bunch of different types of riders. Okay, last thing, co-payments and co-insurance. A co-payment is what you have to pay each time you go to see a doctor. So this is specified in your health plan, and it could be like $20, $50 for a general office visit. It could be a lot higher for like a specialty doctor's. But when you go to check in at the office, they'll say, okay, your co-payment today is $30, and they're going to want you to pay it right then before seeing the doctor. Because if not, they might not get that money. Co-insurance is the percentage that you pay compared to the health insurance or managed care plan. So, for example, the plan pays 80% of costs, you pay 20%. That 20% is your co-insurance. All right. We made it through that slide. I know it was a lot, so if you have questions about one in particular, let me know. And we're going to go through some of this throughout this PowerPoint as well. So moving on. So insurance is regulated by each state. It's not like a federal thing. Each state has insurance regulators that have all of these responsibilities. And I'm sorry in advance for having to read them straight from the slide, but here we go. They register insurance companies. They oversee compliance and penalty provisions of the state insurance code, like making sure they're all following the rules. They supervise new insurance companies that are being made. They monitor the reinsurance market. They requiring authorized insurance companies to meet and maintain requirements for doing business in a state so that they're following all the legal and financial requirements. Licensing insurance-related professionals, so that would be like making sure insurance agents or brokers or adjusters are licensed, and handling insurance claims, processing complaints that are submitted by medical practices. So if a doctor's office is unhappy with how an insurance claim was processed by, let's say, Blue Cross, they can submit that claim to the state insurance regulators and say like, hey, look at this, see if this was properly denied or properly processed. According to the latest census data, 66.5% of Americans are covered by private health insurance, 17.8% by Medicaid, 18.4% by Medicare, and 3.7% by military health care. Okay. Here in the U.S., we have a lot of options for getting health insurance or managed care coverage. These are just the most common ones. So group health insurance is a type of private insurance that is subsidized by an employer or a labor union or something. So what that means is the employer or the other organization will pay for a portion of the insurance, and then that way the costs are spread out among the other group members. So it's not as high for each person. Individual health insurance is another type of private insurance for someone who doesn't have the option to do group insurance. So this ends up being a lot more expensive, right? Since they don't have those costs being spread out between a bunch of other people. Public health insurance is funded by taxpayer money through the state or federal government. So that's Medicare, Medicaid, CHIP, and TRICARE. A single-payer health system is also funded by taxes and run by the government. Canada uses this type of system, so everyone's on the same plan. It's not set up like it is here where you can like pick from a ton of options and pay different amounts with different coverages, right? Everyone's got the same thing. Socialized medicine is a type of single-payer system where the government owns and operates healthcare facilities, okay, and then the doctors just get paid straight from the government. This is what like Great Britain and Finland use. Universal health insurance is a social insurance model that tries to give everyone access to health coverage. with like a combination of private and public health insurance. So the example is the Patient Protection and Affordable Care Act in 2010. The goal of that was to extend health coverage to millions of people that were previously uninsured by requiring them to purchase it. Okay. So there's your knowledge check. Okay, this is a fun little graphic just showing all of the significant changes that health insurance and managed care have gone through since 1850. There's been a lot of changes. You do not need to know these dates or names or anything like that unless I tell you something specifically. So I already mentioned the Patient Protection and Affordable Care Act, or PPACA. The Healthcare and Education Reconciliation Act, HCERA, amended the PPACA to add in some reform initiatives. One of the things that was implemented was the risk adjustment program. So the purpose of that was to try to get insurance companies to stop doing risk selection, which is basically like they were trying to only enroll healthy people, right? Because it's a lot less expensive for them, or people that are considered lower risk, right? That because the higher risk people cost them more money. So the risk adjustment model incentivizes insurance companies to enroll higher risk people, so people with more chronic conditions. The risk transfer formula takes money from health plans that have mostly low risk enrollees and gives that money to plans that have higher risk individuals. It kind of just spreads it out. And this example here is just showing how they calculate risk scores on people, but you do not need to know how to do this. When the PPACA was signed into law, a health insurance marketplace was created. So this doesn't replace other health insurance programs. It just has options for people to pick from that they can afford. Most people that don't have insurance through their work can use this health insurance marketplace as long as you're a U.S. citizen or at least be lawfully living here in the U.S. and you can't be incarcerated. So the website for that is www.healthcare.gov. All right, we already talked a bit about what managed care is, contracts between people or healthcare programs and MCOs, managed care organizations, to give them a discounted rate, or at least that was the original goal. Now doctors have to take on some of the costs because it turned out that people are more expensive to treat than the MCOs expected. An MCO can be a health plan, but it can also be a health system, a hospital, or physician group. So if you remember a few slides ago, most insurance companies reimburse using that fee-for-service plan. MCOs, on the other hand, use capitation. So this is what I mentioned earlier, where they agree with the doctor or the group ahead of time on this set amount. I'll pay you this much each month or this much each year, and the doctors will do handle all of the treatment for their patients. And so, like I said, they'll make more money on someone that has less problems and requires less treatment since they're getting the same amount of money either way. A customized subcapitation plan is when the person gets to pick each type of doctor that they think they would need, and they'll pay a customized premium based on their choices. If someone has to see a specialist, which would be like an oncologist for cancer, or going to see a cardiologist when you have heart problems, then you would use a subcapitation payment. This is a lot like the carve-outs I mentioned earlier, okay? There are several managed care models that you can see listed here. I'm sure some of you have heard of HMOs or PPOs. Each of these are slightly different, but we're not going to go through all of them. Just know that there are different models in managed care. Okay, so I know we didn't go through the differences of those models, but each one is going to have slightly different requirements. Okay, so how will this affect a doctor's office? They're going to have to keep track of all of those different plans that people are using and how each is done differently. So it does create a lot more work for the office, and you have to have multiple systems even to track everything. Okay, so here's just some of the ways that doctors' offices are affected by managed care. All right, if you remember fee-for-service let's see. Fee-for-service plans reimburse doctors based on what the fee schedule is. Now, a lot of health plans are using a value-based reimbursement method, which pays the doctors based on quality of care, and they do this with patient outcomes. Patient outcomes are basically what happens to the patient after they receive care. You know, do they have to come back to the hospital for more care, or were they okay after the treatment? To put it simply, right? So this method is much better for us as patients, right? Because a doctor won't get paid as much by just, getting patients in and out of the door, right? Like based on numbers. They have to make sure that what they're doing is the best option for the patient in the long run. Okay. When you pick a health insurance or managed care plan, you also choose a primary care provider or PCP. That's who manages your care and takes care of referrals if you need to see a specialist or be admitted to the hospital. For managed care plans, the PCP is referred to as a gatekeeper. They provide services at the lowest cost possible, and then they refer patients to specialists for any extra treatment. Physicians do receive incentive payments to reduce or limit the services to try to save money for the managed care plans. So they're encouraged by money to say, discharge you from the hospital as quickly as possible, as long as you're okay, so that the plan doesn't have to pay for any extra nights. The federal government does require these incentives to be disclosed. Okay, so they're not hiding it. It's publicly known that physicians are trying to do more with less, basically. All right, health insurance and managed care plans both participate in quality assurance and performance management with the goal of improving patient care. Quality assurance looks at enrollee complaints to see if they got the best quality of care. Okay, performance measurements is measuring to see if the treatment someone got matches what the guidelines say should happen. And they also look at what happened to the patient after treatment. What were the results of their care? Most states have external quality review organizations that oversee all of these things. So these would be quality improvement organizations and accreditation organizations such as the National Committee for Quality Assurance and Joint Commission that go in and survey facilities to make sure that they're in compliance and doing everything the right way. Okay, I just mentioned this. The NCQA will audit managed care plans and then release their findings to the public in what's called a report card. So that way people can make informed decisions, right? They can look at all of these report cards and see, which one's right for them when they're trying to pick out a plan. This group developed the Healthcare Effectiveness Data and Information Set. It's known as HEIT, which is the list of standards that they're looking at when doing an audit. All the things that are supposed to be done. And standards are requirements created by accreditation organizations. So for a facility or plan to be accredited, they have to be following this set of standards, which, this being accredited kind of just gives them status, right? We're accredited, so you should come use us instead of that place over there that's not accredited, okay? Because we're following all of these strict rules, and they're not necessarily doing that. Okay, that's what being accredited is. Quality improvement is just continually doing these certain things to try to make things better for patients. The focus is on patients and doing what's best for them, which is how it should be, right? I think the focus had gotten to be too centered on making or saving money. And so they've made a lot of strides to try to fix that. CMS created the quality improvement system for managed care to do all these things. Also, doctors started to be incentivized to voluntarily do quality reporting. They use quality improvement programs. They use these clinical practice guidelines, and these list out basically, if a patient has a diagnosis of high blood pressure, these are your treatment options, okay? But for every diagnosis. So these aren't requirements that doctors have to follow, but these are the things, the options that should be done for the best quality of care for the patient, okay? Best outcome in the long run. All types of health plans use utilization management to help with keeping costs low while still providing, the best quality of care. So they do this by following a patient the whole time they're in the hospital. For example, say they're in the hospital. So before the patient is even admitted, the utilization reviewers are looking at, okay, this patient has these diagnoses. So these are the things that should happen while they're in the hospital. These are called pre-admission reviews. Then while the patient is in the hospital, every day they're doing a concurrent review to make sure that there's still that medical necessity for the patient to be there and that they're receiving all of the appropriate treatments and medications, okay? They also do discharge planning to make sure the patient doesn't stay longer than they need to. Some managed care plans contract this out to specific utilization review organizations to do all these things for them. Okay, case management is similar. This is making patient care plans for the more complicated cases. So somebody that has maybe a lot of health issues that a hospital's trying to treat a bunch of things. The case manager will kind of coordinate all of the treatment, make sure that the patient's getting everything they need, while again, still trying to keep costs down. Case managers are usually like nurses or social workers. Before scheduling any sort of elective surgery, managed care plans will usually require a second surgical opinion, which is where a second physician will look at the case and see if the surgery is necessary and recommend, what the best place for it to take place at. Can it be done on an outpatient basis or in a doctor's office instead of as an inpatient in the hospital? All right, and don't worry about those last couple of bullets down there. Managed care organizations offer second opinions if a patient's condition is unclear or if the patient's not sure about their treatment plan or if the treatment's not working, okay? So this is asking a second doctor to see what they think the best course of treatment would be. If the first and second opinions are different, then the MCO will also provide a third opinion. Prescription management is used to help control medication costs. Are y'all starting to see a pattern? All these things are trying to save money, but still provide quality care, okay? So these are the strategies that prescription management uses. Pharmacy benefit managers, they kind of just run these programs. Cost sharing, co-payments, or co-insurance, so the amount that the patient will pay. Disease management programs, these make sure patients are getting the correct dosages, so not too much or too little. Electronic prescribing or e-prescribing, this is where the doctor can send the prescription straight to the pharmacy while the patient's still in his office. Drug formularies, this is a list of brand name and generic prescription meds that a health plan covers. Drug utilization review, making sure patients are using meds safely and correctly. Generic substitution. So generics are basically the same formula of a medicine, but cheaper. Okay, so for example, buying, the Equate brand of ibuprofen instead of the Advil brand. It's going to be a little cheaper, but it's basically the same thing. Manufacturer drug rebates. Some manufacturers do offer coupons to help discount their meds. Negotiated prices is deciding on a set price, usually discounted, with network pharmacies that they're going to work with regularly. Prescription mail services, this is where the meds are shipped straight to the patient. Okay. And guys, I know this PowerPoint or this chapter is a little bit longer than the first. This is probably one of the longest ones, so bear with me, okay? All right, consumer-directed health plans, or CDHPs, are thought of as like a 401k for healthcare. So with these, you have a little bit more freedom in how you spend a certain amount of the money you're putting into your health plan. And then you also have full coverage for in-network, like preventative care. The downside is once you spend that designated amount, you pay like a great portion of the remaining expenses. One thing to note is that all of these are tax exempt, and I'll explain that just really quickly. So, say your paycheck is $500. A portion of that is going to go to federal and state income taxes and FICA taxes. But if you put $500 into one of these CDHPs, you won't have to pay any of those taxes on this money, okay? Then you can use that money to pay for like your co-payments or your prescription meds or things like that. There's typically like a list of things that you can use this money for. So the tax benefit is a big plus. There are a few different types of CDHPs, all with just slight differences. You may have heard of some of these before. Flexible spending accounts, or FSAs, healthcare reimbursement account, health reimbursement arrangement, and health savings account. Okay, switching topics a little bit, let's talk about healthcare documentation. So healthcare providers are responsible for documenting and authenticating patient records. This is required by the Medicare Conditions of Participation and Joint Commission. So they have to document legibly, timely, meaning very soon after the treatment or whatever happened, and completely. They have to be very thorough, because if something is not documented, it's as if it wasn't done. They also have to make corrections when there are errors. The patient record or medical record keeps track of all of the diagnoses and services that are done for a patient. The main purpose is continuity of care, right? So a doctor should be able to come in and read a patient's medical record and get a good understanding of what's going on with them so that they can then do what they need to do for the patient. The secondary purposes are to evaluate the quality of patient care. They're used for clinical research and to send to insurance companies or third-party payers to get reimbursement. Also for legal purposes. So like if there's a lawsuit against a doctor, which is another very important reason why there has to be, thorough documentation. So there's a record of everything that they did and they can prove it. All right, there are general documentation guidelines that let residents and teaching physicians also document in patient records, because at teaching hospitals, the residents are treating patients, like they're doing most of the treatment, just under the supervision of a teaching physician. The teaching physician is there for all the major decisions or the critical parts of a procedure, but when they're not there, that resident's doing it, but they have to be very nearby, or be able to be there very quickly just in case. All right, another reason documentation is important is for coding purposes. So we touched on this last week with medical necessity, right? If a patient is having a procedure done, then there has to be documentation explaining why they're doing the procedure, because if not, the third-party payer will not pay for it. And I think I said this a few slides ago, but this is a common phrase. If it wasn't documented, it wasn't done. A problem-oriented record is one of many systems that a facility can use in documenting. It has these 4 components here. The database will have the patient's chief complaint, any conditions or diagnoses that they're currently dealing with, all of their social data like date of birth and stuff, any past medical and social history, their review of systems, their physical exam, all of their baseline lab work, okay, all of those types of things. The problem list is like a table of contents for the patient record. It's actually filed at the beginning, and it has like a numbered list of all the patient's problems. The initial plan is exactly that. It's the plan for how they're going to treat the patient. And this also includes anything that they have to do to continue to figure out like what's wrong with the patient. And progress notes are where they document, what the patient said was wrong with them, any observations that they've made about the patient, like what the doctor's opinion is, what the plan's going to be, things like that. Okay, a lot of times people use electronic health record and electronic medical record interchangeably, but they are actually different. So the electronic health record is more of a global concept where doctors from different places can all document their treatments of a patient into one place, okay? This is considered record linkage, and ideally there would be like a unique patient identifier assigned to each patient. And this is all to work towards that continuity of care I mentioned. You can read these last 5 bullets here yourself, but the gist of it is say someone gets diagnosed with cancer here in Baton Rouge. If they want to, they should be able to drive to Houston, Texas, and be treated at MD Anderson without any issues or delays, right? This electronic health record makes that happen seamlessly, okay? Now, the electronic medical record is more of a narrow focus, meaning it's a patient record created at a doctor's office that doesn't transfer anywhere else. It still has all of those things I mentioned, the medication list, the problem list, etc. But if this patient goes to a hospital, all of their record can't be just pulled up in their system. The patient would have to either get a copy of their records and bring it like physically printed with them, or the hospital can request the records to be faxed over to them, and then typically they'll scan them into their system. Okay. Total practice management software is what's used to create the electronic medical record I mentioned. It automates all of the functions that used to be done manually in a doctor's office. So patient registration, scheduling appointments, insurance claims, generating patient statements, payment processing, like when they receive payments from the patient or an insurance company, and administrative and clinical report generation. That's all done by this total practice management software. Okay, CMS maintains these electronic clinical quality measures, which take data from the EHR and see if the correct quality of care is being provided, right? Making sure the care is safe, effective, equitable, and timely. And then there are promoting interoperability programs. That's main goal is for patients to have better, cheaper access to their health information. Okay, the quality payment program was created, excuse me, to try to help doctors focus on giving patients quality care and making them healthier. So it includes the alternate payment model, which incentivizes them to give highest quality of care at the lowest price. The advanced alternative payment models, which is just like the first bullet, just goes a little bit further. There's the traditional merit-based incentive payment system, or MIPS, and MIPS value pathways, or MVPs. You don't need to know the ins and outs of these. They're just there to help the doctors give the best quality of care they can at the lowest price. And the last thing is called benchmarking. So all of this data is published so that doctors can compare their data against other facilities and kind of see where they stand and hopefully, continuously improve. Okay. Okay. That's it for chapter 2. Again, I know that was a lot of information, and I know that we didn't go too deep into any one topic, and sometimes that can make it hard when you don't have a full understanding of each thing. So if you have questions about any of this, please let me know. Shoot me an email. We can set up a Zoom or just email back and forth and talk about it. All right. Thank y'all. Good luck this week.